Good evening, friends. A meeting after a long time. Today's Major Beg Oncology classes will present before you the cancer control program in India and where we are as of now and what we have achieved. So the topic of presentation is cancer control in India. Myself, Major Dr. Vivek, Professor JK Cancer Institute, Kanpur, Uttar Pradesh. There are several programs being launched currently. The National Cancer Control Program is being extended to the National Program for Prevention and Control of Cancer, Diabetes, CVD, Stroke, that is called as NPCDCS, means the cancer is being extended and amalgamated with several disease and non-communicable disease. And this is the biggest setback for us because the cancer is required a heavy budget for a development of a cancer institute. Now it is the money is being shared among all the other disease. Cancer control aim is to reduce the burden of a cancer in a given setting by the resources appropriate investment and interventions. The burden of cancer refers to the number of incident cases, cancer death, suffering due to cancer, cancer healthcare expenditure to the individual as well as to the government. That leads to the cancer leads to the loss of productivity, socio-economic implications to the family and the society at large, psychological burden in terms of social stigma and discrimination, and a poor quality of life. These are the problems associated with the cancer patients. Now, the India has a step ahead in form of collecting the data regarding the cancer. If unless until we know the burden of types of a cancer, we cannot hit the target. So ICMR has launched the National Cancer for Disease Informatics and Research, and then further ramified in the HBCR. And now most of the cancer hospitals, Department of Radiotherapy in the cancer or pathology is having a hospital-based cancer registry system in order to collect the data, type of a cancer, age related, so that we can understand the amount of a problem in and around us so far as the cancer burden is concerned. So the cancer registry, National Cancer Registry in India is launched since 1981, is doing a very good job in order to produce a magnitude of a problem. It is interesting to examine how a large country like India, with a population of 1.35 billion people, with a highly varying socio-economic and health services developments between the region, state, and how the situation tackles the cancer control. And the second point, what has been the impact of already implemented cancer intervention program, the National Cancer Control Program launched in 1975, and what challenges lie ahead with and what are the pragmatic solutions are before us. So the cancer burden in India, the data of 2018 shows that the 11.6 lakh new cases, 7.85 lakh death per year, and a 22.6 lakh prevalence rate cases per annum around 2018. And out of that, more than 75% of newly diagnosed cancer patients present in a clinically advanced stage. Now I'll tell you what are the problem, why this problem is arise, why we are getting a advanced stage cancer patients. Approximately more than half of a patient die within 2 years of a diagnosis, and a two-thirds of a patient dying as a result of their disease within 5 years from diagnosis. This is the situation. So only one-third of a patient survives, indicates. And also we have a data, a term like a mortality to incidence ratio. In India, we have a 6.68, that is MI ratio, that is mortality incidence ratio, as opposed to 3.5 in the developed countries. That means there is some flaws is there, which we have a such poor result in compared to the European countries. So I told you regarding the hospital-based cancer registry, and a population-based cancer registry is working uh, mm, very nicely in a country like India, where 2020 they have reported that 13.92 lakh cases, and 2021 14.26 lakh cases, 2022 14.61 lakh cases, and they projected that the 2025 the projected score is more than 15 lakhs cases yearly, new cases. This ICMR data is being presented in the parliament, so that you see the trend from this 2020s onwards, that the incidence of cancer cases is rising, and we have to search out the pragmatic solution by deciding the pragmatic solution, practical solution, how to curb the disease. Then it is also interesting that in estimated incidence in 2020, 94.1 per lakh male affected. And contrary to the female, they have a higher incidence of 103.6 per lakh female per year. And the common sites is the lung, mouth, prostate, tongue, and stomach, almost comprising around 36% of all cancer cases among male, and a breast, cervix, ovary, uterus, and lung comprises 53% all cancer cases among the female. This data we have acquired from the National Disease Informatics by ICMR. So we can also see that there are a population-based cancer registry network all over the India, almost 26 to 28 almost now. We can see in this map that the Prayagraj in the UP, the Kamla Nehru Hospital having being labeled as a hospital-based cancer registry network. They collect the data and send it to the ICMR. There is also, they have not mentioned in this map, the HGPGI. They also having a hospital-based cancer registry network. They record the data and send it to the higher center. Now, this population-based cancer registry was very, in a state like UP, in such a large state, we have only two. So they have further ramified the ICMR, that they started the hospital-based cancer registry, so that the data can be further strengthened and can be research work, and data collection can be done at the little lower level, as at medical college level, institute level. So major contributing factors for these discrepancies are: first, lack of public and professional awareness. Multidisciplinary approach is lacking, like cancer prevention, early detection, treatment, and follow-up care. Inadequate availability, access to cancer healthcare services. Lack of adequate healthcare financing in India, because the treatment is very costly, so that financing is required. Inadequate infrastructure, human resources, and a healthcare financing mechanism. All these factors lead to the catastrophic out-of-pocket payment for a cancer treatment. India has formulated a national cancer control program way back in 1975 as a national cancer control program, which has been revised many numbers of times since then. Currently, India has incorporated the cancer control initiative, especially primary prevention initiative targeting on the tobacco control, alcohol control, prevention of overweight, obesity, promotion of physical activity, healthy diet, and healthy lifestyle as a part of integrated national non-communicable disease control program. But do you think that can control the cancer? The primary prevention certainly can be controlled, but we don't taking into account that the cancer is basically a heterogeneous nature. The heterogeneous nature of a cancer means what is the means? The cancer, a different cancer required a different etiological factors, different igniting factors, as well as the prevention and control of a cancer. Also, different cancer required a different measures. So you cannot kill the two birds by one stone. That's very simple. So cancer is a group of a disease, not a single disease, but require varying and differing control measures, particularly in terms of diagnosis, treatment, and follow-up care. So there is an important need for developing the implementing the focused first time-bound cancer control program supported by adequate budgetary outlays in the different state in the country according to the cancer incidence. As of now, the formulation, the scope, integral components, budget allocation, and the extent of real implementation of these plans in the different state of India is highly variable and far from desired level. Very sadly, um, I can point out. This is not surprising given the varying level of socio-economic development and a political commitment to improving the healthcare in different regions and state of the country. In this context, it is useful to examine the organization of health services in India and to examine how cancer control has been integrated and how it is how its integration can be further improved so that more cancer effectively prevented, diagnosed early, and treated effectively and cured. So how the healthcare expenditure can be financed and the cancer healthcare made affordable to all segments of the society equally. The major advancement in the cancer control in India is a valid estimate of incident of a cancer, documentation of a cancer, incident rate of a pattern in the various regions in the country. As I have told you already, the ICMR is working very good, very nicely under the central government, particularly in the south and the northeast region country by 26 population based cancer registry of National Cancer Registry Program in India and a few cancer hospital based cancer registry working nicely. So the cancer registration in India has led to valid estimate of a cancer incidence and a cancer pattern across the country, providing the important lead to the cancer control. Control measures focusing on the tobacco related cancer like head and neck cancer, lung cancer, and a chronic infection related cancer like HPV related cervical cancer and stomach cancer by a virus and the hepatitis B leading to liver cancer. So physical inactivity, overweight, obesity related cancer like breast, colorectal, early detection and adequate treatment of curable cancer like a breast, cervix, and colorectal oral cancer can lead to the substantial reduction in the cancer burden in India. The cancer in India, as gleaned from the estimate based on the finding of Indian population based cancer registries, which the data I have already shown you the incidence and rate of cancer. Then you can see the breast cancer incident rate and the other cancer, main oral cancer, esophageal cancer. So, in the nutshell, that 1 out of a 10 Indian will develop a cancer, and 1 out of 15 will die of a cancer in their lifetime. That's a punchline here in this slide. We should note. Although the India is a signatory to the Framework of Convention on Tobacco Control since 2004, and it's increasingly implementing the FCTC regulations, it could do much better in regulating and curtailing smokeless tobacco use and the increasing consumption of areca nut containing a chewing product, particularly in form of pan masala, which is now the leading cause of a buccal mucosa cancer, which is the highest cancer in the oral cavity, highest incident cancer of oral cavity cancer, commonly occurring in the young people in the country. And because of these, the incidence of oral cancer in those aged group 30 to 55 years has increased 2 to 3 fold in the last few years. So Indian masala market, that's finance is involved here, and you see the beauty of here in this slide. The Indian pan masala market has reached a value worth around 35,521 crores, 5 billion US dollar in 2017, and it is projected to reach 60,198 crores, 8.6 billion USD in 2023. So much of a financing involved. The taxation services is getting a very huge tax from these. The government is confused what to do with this. So that is the biggest problem with this. Otherwise, we could have banned this product quite fearlessly and boldly. While hepatitis B vaccination is implemented as a part of a national immunization program, human papilloma virus vaccination is currently implemented by the state of Punjab, New Delhi Capital Territory, and Sikkim. There is still substantial misinformation on the safety and value of human papilloma virus vaccination in cervical cancer prevention in India, despite the evidence to the contrary. It is useful to examine the organization in India healthcare services in order to consider how the cancer early detection, treatment, and follow-up care services are embedded in the public health system, and what lacuna exists and how these can be addressed. So let us just see what is the primary health care services. The health services is form of a health center, and the smallest unit population norms is 3,000 to 5,000 population in a village, and the primary health center is comprising among the population of 20 to 20,000 population, and a community health center is based on 80,000 to 1.5 lakh population in the rural area. The health centers are manned by the health worker only, and the PSCs is governed by the 1 or 2 doctor, 3 or 4 nursing staff, and a laboratory technician, and a 4 to 8 beds mainly provided for outpatient patient service and the limited patient care. So the public healthcare infrastructure in India with relevance to cancer control, that we have at 25650 PSCs. Out of that, 15700 PSC function with only one doctor only, and a 5624 community health centers, 763 district hospital in India. And so far as the medical colleges is concerned, 479 medical college and hospital. Out of that, 227 in the public sector. So mainly 719 districts in India lack a medical college. the 220 focused cancer treatment facility in district hospital and medical college hospitals. So out of 479, now the data must have been increased. The UP is increasing a medical college at the very fastest speed. So data is supposed to be changed now. But even the most of the medical colleges do not have a cancer treatment facilities. The cancer treatment facilities are limited to, out of suppose almost 500 medical colleges, the 220 medical colleges do only have cancer treatment facilities with this limitation also. But we have only 27 regional cancer center, comprehensive cancer treatment center, where you can get a surgical, medical and radiation oncology services, and 8 Epics Cancer Center. They are a corporate hospital that is dedicated only for a cancer treatment. This is the data which we have. What are the existing component of a program run by central government and a state government as well? The national NCD cell, the state NCD cell, tertiary cancer center, district NCD cell, district NCD clinic, daycare cancer center, cardiac care unit, CSC with NCD clinic,